This is a case of bilateral congenital cataract secondary to tortuous infection in a 1-year-old boy. 2 cornea side ports are made at 2 and 10 o'clock with 25 gauge NVR blade. Triphon blue dye is injected into the AC for approximately 20 seconds to stain the anterior capsule. Viscoelastic is injected to form the AC. We use Discovis in this case. A 25 gauge vitrectomy probe and an infusion cannula are introduced through the side ports. Anterior capsular opening is achieved with a vitrectorexis with a low cutting rate of 2000 cuts per minute, IOP of 25 to 30 mm mercury, and an aspiration flow rate set at maximum 600 ml per minute with a linear pedal control. Cutting edge of the vitrectomy probe is face down in contact with the anterior capsule to make an initial central capsular opening and then further enlarge towards the peripheral until the preferred shape and size of 5.5 mm are achieved. As it is known that anterior capsulotomy in younger children is very challenging because they have a very elastic capsule and not easy to control. One of the advantages of vitrectorexis over a manual CCC with a cystotome needle or Utrata is the chance of extensions or radial tear of anterior capsule towards the peripheral is extremely low. Lens metal is aspirated using the same probe with the cutter off setting. We engage the bimanual approach in this surgery whereby the cutter and infusion cannula sites are exchangeable where needed. The vitrectomy cutter was turned on while aspirating the denser nucleus and turned off again while aspirating the soft lens metal and cortex. With a 25 gauge vitrectomy system, AC stability is well maintained. A 25 gauge MVR blade produces cornea incisions of 0.5 mm, which matches with the size of vitrectomy probe and infusion cannula, so there is no wound leak during the surgery. This can reduce the risk of repeated iris prolapse, PC-RAN, and a post-operative intraocular inflammations. Moreover, the IOP maintained at a more physiological state and the aspiration rate can be controlled with a linear foot pedal. After removal of all the lens metal, capsule is polished using the same vitrectomy probe. Thorough cleaning in pediatric cataract is crucial to reduce inflammations and capsular fibrosis. After the cataract aspirations, posterior capsulotomy is done with the same vitrectomy probe. The size of the posterior capsulotomy opening was a little bit smaller than the anterior capsulorhexis. Anterior vitrectomy is performed with a maximum cut rate of 7,500 cuts per minute to reduce the risk of vitreous tractions. We use intracameral triamcinolone to ensure there is no vitreous in the capsular bag and aim to reduce post-operative inflammations as this is a case of tortuous-related congenital cataract. As demonstrated, anterior and posterior vitrectorexis are more precise, controlled, and quick with vitrectomy cutter. And now, viscoelastic is injected to inflate the capsular bag. Side port at 10 o'clock is enlarged to 3 mm using a 2.75 blade for IOL insertion. Single piece SA Acrisoft IOL was implanted with the target refractions of +3 diopters. Viscoelastic is removed with the same vitrectomy probe. Both cornea incisions were closed with a 10-0 vicryl. 3 sutures is put on the wound at the IOL insertion site and 2 sutures on the side port. So we put on a total of 5 sutures. Subconjunctival injections of cefuroxime and dexamethasone are given at the end of the surgery. On post-op day 1, the child was able to freely open his eyes, very minimal conjunctival congestions at the incision site, which resolved at 1 week post-operatively, and the pupil is round with no opacifications at the visual axis during the follow-up period. As you have may notice, only 2 instruments are required to perform majority of the surgical steps, which are anterior capsulotomy, lens metal aspiration, polishing of the lens capsule, posterior capsulotomy, anterior vitrectomy, and the OVD removal. In summary, pediatric lens aspiration via corneal approach 25-gauge vitrectomy system is an alternative to traditional surgical method if the facility is readily available. It is easy to perform, safe, effective, and less time-consuming in the management of congenital cataract in younger children.